Second speaker is Jonathan Rosen, and we're very lucky to have Jonathan. He has a wealth of experience, and the reason that I kind of reached out to Jonathan was through an American Industrial Hygiene Conference exposition. He was a presenter, and he did work for the National Clearinghouse for Workers' Safety and Health Training. And Jonathan also has really good US insight into the recent emergency temporary standard that he wants to touch on as well. So I'm going to hand you over now to Jonathan. Thanks, Jonathan.
Thanks, Kevin. I'm excited to be part of this panel today, and I'm going to start off by talking about the OSHA Emergency Temporary Standard. And just to kind of ease into it, what led to the Emergency Temporary Standard, it was a recognition by safety and health activists, unions, progressive legislators, community members, that workplaces have been a primary source of COVID-19 outbreaks. And we know that thousands have been infected and died. And in the US, racial inequities have been a big factor because low-wage jobs require people to physically be at work. And so these are more highly represented by racial minorities and immigrant workers and low-wage workers. And they also have the risk factors in the communities where they live. They tend to be in more congregate housing and lack access to health care, and use public transportation, which is also a factor because you're crowded. We had 190 deaths in the transit system in New York City. And one of the problems is that the public health system, kind of following Mark's comments, the public health system in the US and in many parts of the world is being dismantled. Anti-government, anti-regulatory policy has caused layoff of public health workers. And so our ability to do outbreak investigation, contact tracing, was really hampered by that when COVID hit. And it seems that every time there's a pandemic or an outbreak, there'll be funding for a year or two, but then that funding disappears and the preparedness just isn't in place to cope with what needs to be done. Under the previous leadership in our country, there was very little activity at OSHA in terms of enforcing their current enforceable standards on respiratory protection, the general duty clause, which is used when there isn't a standard. Though that was probably the most important one, was the respiratory protection standard. There were several states that issued emergency temporary standards. I'm using the acronym ETS. And some states had executive orders, but this is part of the chaos of this whole experience and why the US had one of the highest rates of infection and death in the world. Is we really didn't have any coordinated federal strategy. Each state was left to their own devices. And in that anti-regulatory environment made it really difficult. The picture is showing you meat cutters, and you can see how close together they are and how inhalation of the virus can be a factor. And keep in mind, it doesn't necessarily have to be a patient.
Sorry, Jonathan, I'm just checking in. The slides aren't advancing. You've still got the very first slide.
Thank you. I'm clicking on the wrong thing, I think. Now are they advancing?
Yes.
Yeah. So I was showing the picture of the meat cutters. You can see how close together they are. So if somebody either is asymptomatic or comes to work because they don't get paid sick leave if they don't come into work and they have to pay their bills, they can infect their coworker. And so this is a phenomenon where it's not only an occupational hazard, but the community level of contagion is a factor in the workplace and vice versa. So here's the background. The new president, issued an executive order directing OSHA to take action by March 15th. And OSHA finally took action on June 1st. And you can go to the website and see all of the documents. I'm going to give you a quick overview of what they did. The effective date is 2 weeks after publication in the Federal Register. I'm not sure when that's going to be published, hopefully soon. And the guidelines are limited to healthcare and not the entire healthcare industry, as you'll see in a minute. Part of it is this disconnect that Mark was talking about between the real experts in aerosol physics and inhalation and aerosol science were not at the table. So in the US, the Centers for Disease Control, CDC, is the lead federal agency for infectious disease outbreaks. And they were reluctant to recognize inhalation of SARS. And it kind of dates back the science that they're using over 100 years, the science that focuses on droplet transmission as the way that people get infected by things like influenza and coronaviruses. And so there's been a lot of effort by the scientific community and the labor community and allied legislators to reverse that. And WHO, the World Health Organization, CDC have made some acknowledgement of the inhalation hazard, but they've done nothing to change the guidelines for the workplace. And OSHA is basically constrained by what CDC comes out with. So that is why we have this fairly weak standard that only covers a very, very small sector of workers who are at high risk of getting infected and dying from coronavirus 2. And you can see, I'm not going to read this to you, but highlighted is the coverage is only healthcare facilities where there are suspected or confirmed COVID patients being treated. Well, and also non-healthcare settings such as a walk-in retail clinic or medical clinic in a manufacturing setting, but only the coverage is only for the embedded healthcare setting. Well, the problems with that are numerous. It doesn't recognize that asymptomatic patients or asymptomatic coworkers could be a source of occupational exposure. And here is the document OSHA came out with, and you can't read it, but even if you could, you probably would have a hard time figuring out what the hell it means. It's kind of one of those complex constructs about who's covered. And exempt, there's a lot of exemption. Certain hospital and non-hospital ambulatory settings where non-employees are screened and those with suspected or COVID-19 are not permitted or present. But of course, you screen somebody for fever, but if you're asymptomatic, you're not going to have a fever. You can still be contagious. If you're pre-symptomatic, you're not necessarily going to have something that would be found in screening, but you could be contagious. So this is flawed, in my opinion. In the US, we saw a tremendous amount of infection and death in nursing homes and long-term care, corrections, meatpacking, and all these other industries that are listed on the slide, which mainly are not included in this ETS. This is just a picture from the Wall Street Journal of some of the workers who died from COVID. And most of these deaths were not reported or investigated. And that's still the condition because we need to build up the public health infrastructure so that it can deal with the current pandemic and future pandemics which have been predicted. And we need a seat at the table for labor unions and for health and safety professionals, and particularly that we need the voices of those scientists that have dedicated their careers to aerosol science and aerosol physics. They also are exempting vaccinated workers from masking, distancing, and barrier requirements in well-defined areas where people aren't supposed to be there if they're suspected or confirmed with COVID. Again, it doesn't recognize asymptomatic or pre-symptomatic spread. Here are the elements of the requirements of the standard, and this is a step in the right direction. And I don't really fault the people running OSHA at all. They're constrained by the CDC and the situation that I've described. So written plan for work sites with 10 or more, all of these requirements, the focus has been on what they refer to as aerosol generating procedures, which are narrowly defined as things like bronchoscopy and sputum induction. These are healthcare procedures that, but we know that breathing and talking and coughing also generate aerosols, and that can be a source of infection. And we know that physical distancing and barriers alone will not stop the spread of aerosols. They can go much farther than 6 feet, and they can build up over time in the room if you have a highly contagious person that's emitting them. These are other requirements on the right, and I'm going to focus a lot on training because that's what I have been doing, and there's a resource I want to share with you that you can benefit from. There's also anti-retaliation and vaccination and medical. The employers have to pay workers who are in quarantine or on medical leave under this standard. So there's a lot of good things in here. It's just not covering enough people and not extensive enough, in my opinion. They've also added this mini respiratory protection program that exempts the requirement for medical evaluation and fit testing and a written respiratory protection program. And this only applies if people are wearing respirators where the employer has not determined that a respirator is required. Well, again, I have a problem with this because in the nursing homes and long-term care industries, they generally don't comply with the OSHA respirator standard requirements. They often don't have a written program, a respirator program administrator. They don't do the medical screening of the workers to make sure that it's safe for them to wear a tight-fitting respirator like an N95. And they often don't do fit testing. Instead, workers were given surgical masks or cloth masks, which we know are have both inward and outward leakage, and so you are going to be exposed when you're wearing a surgical mask to a lot more aerosol than you are if you're wearing a properly fit tested and a properly sized, tight fitting respirator. So this is trying to deal with the fact that there's a crisis, and I think that's why they put it in here. But really, I think what we need is to get these facilities like where there's been a lot of infection to comply with the full respirator standard, and to use other engineering controls like ventilation and administrative controls, like limiting the number of people that might be exposed to a potentially infectious person. Here's more about this mini respirator standard, and you can read it to get the details. I'm now going to turn to the issue of training, and this is just some of the evidence about why training of workers is so important. And one of the issues is training has really been, compromised, especially in healthcare. They tend to work 12-hour shifts or double shifts, and they'll tell the healthcare worker, well, during your 20-minute break, look at this video or this computer screen. That's not meaningful training. We want training that's interactive, hands-on, that's comprehensive. And these studies are showing that that type of training is much more impactful in terms of people really being protected. NIEHS, which is the National Institute of Environmental Health Sciences, federal agency, was able to get $10 million in funding, and they were able to fund grantees to do worker training during COVID. And these were some of the key objectives. We wanted to use evidence-based information. We wanted to use virtual training platforms because of the fact that we didn't want to have people close together spreading COVID during worker training. And how do you build a cadre of trainers during a crisis? And here's some more of the deployment challenges. We developed train the trainer programs. You can go to the website. It's coming up on a slide, and maybe somebody can post it in the chat box. And these are public domain materials that are designed for anybody to adapt, modify, and make their own. A big problem is, how do we get employers to commit the time and resources to training? And here is a list of the resources. They're in English, Spanish, there's PowerPoint and PDF versions of them. We have the Essential Worker course also in Vietnamese and Chinese. There's numerous webinars. There's a toolbox that has the reference list that went into the evidence that went into the training. There's many fact sheets, checklists, even a fact sheet about how the COVID pandemic and the opioid crisis in the US is being fueled by the stress and mental health effects of COVID. And many vaccination fact sheets, including one on protecting the vaccinators. And these were the first two programs. One was a general awareness program. The other was for essential and returning workers, which we've just upgraded and retitled because really everybody is essential that has to work. And there's a big move to get everybody back to work. And so now the new title is Building Programs to Protect Workers from COVID-19 in the Workplace. It's designed as a 4-hour program, but you can modify it to the amount of time that you have available. And it should be tailored to your site-specific needs. And we try to emphasize that you need to keep your eye on the changes that are occurring, sometimes daily, to update your training materials accordingly. These are the goals and objectives, and they're actionable. The idea is that workers should leave there being able to do something. And in this case, it's being aware of the risk factors in their workplace, define protective measures that should be implemented in their industry, know their rights to a safe and healthy workplace, and review strategies for mental health. And this is the construct of the course. And this is not operations training. We're not hands-on donning and doffing respirators, PPE, hands-on with decontamination, etc. So this is kind of a warning that that type of training is required and necessary. So after resuming work, it's really important that workers know what the risk assessment is and the changes to the work site. Often that has not been done, but that's a key part of training as well. We thought that using photographs was a powerful mechanism. We would ask people, what's wrong with this picture? The one on the left is a New York City cop. You can see a beard, wearing a surgical mask, no gloves. If they were around a person making an arrest or an inquiry, they could be exposed. The post office, I don't know if you can see that there's some material here that's supposed to protect him, but it's not going to prevent aerosols from going into his breathing area. No face covering. So this is the type of thing that, here one of our grantees, using popular education, took outbreaks that occurred, at some work sites, retail work sites, and they developed case studies and then used the small group training method for people to talk about what went wrong and how they could prevent it or react to it in their workplace. So this is a really great method, and I would encourage people to consider it. One of our partners is in the construction industry. One of our grantees is the Center for Construction Research and Training, and they gave us this slide, which is showing avoiding choke points at a construction site and other examples of choke points. And again, that could be in any industry where you could develop a slide or a discussion about choke points. Here's a safety meeting, which is standard in the construction industry, but we don't want people on top of each other. So that's why we have the big red, do not assemble in this manner. We want the safety talk, the toolbox talk, but we don't want the risk. And then the mental health issues are huge. Even before COVID, I think mental health in the workplace is not highly recognized, and all of its manifestations. There's a lot of stigma attached to people coming forward if they're struggling. And this is from the CDC showing big increases in mental health effects and that type of thing. And these are some of the stressors during COVID that people are experiencing: layoffs, job loss, fear of infecting their family or themselves, death of a family member. So these mental health issues are huge, and we need to have programs and resources. We've seen record numbers of suicides and deaths from overdose in the United States. In fact, during COVID, we've had another year where we've had a record, in the lowering of the life expectancy in the United States. And so, I'm not sure what the parallel situation is in Canada, but I'm sure that mental health issues are important and something that needs to be addressed. And we're not just talking about self-care, but that is an important aspect of it: healthy eating, sleeping, exercise. But you need to have the organizational supports and not strictly the individual approach. And then we end the training by doing some action planning, and we kind of break it up as actions that an individual worker can take: sharing fact sheets and information, talking to the supervisor or the union rep, things like that. And then there's things that can be done on an organizational level. So if it's a union official or an activist, it might be, taking this to the Health and Safety Committee, filing a complaint. If the employer won't do the right thing, filing an OSHA complaint or a complaint with the mayor or the health authority, etc. And a key is to have a process, accountability, and a plan to follow through. And the final, to get to the end of my presentation, the research I did showed only 16 out of the states in the country had any training requirements. And so the new standard that OSHA has does have training requirements, which is really a great thing about it. But we need that training to be extended, to the other employment that's at high risk of infection and death, and not just limited. And it needs to, we need to make sure that it's hands-on and implemented with worker involvement and union involvement. So here's some of the biggest challenges. No OSHA requirement for worker training except those covered by the new ETS. Difficult to establish training during the disaster. We really need to do that during the preparedness period, which we're kind of entering into, at least in the US at this point. And the hardest hit industries during the crisis had major staffing shortages and were working overtime. So the likelihood of getting them to do training under those conditions is slim. And low wage industries don't have a culture that invests in worker safety and health, including training such as meat packing and chicken processing, retail, nursing homes, etc. So here's some of the resources. That's the link to the NIEHS website. And the American Industrial Hygiene Association developed a lot of great back to work materials, as did the National Safety Council. What I don't have listed here is some really great fact sheets. Maybe Kevin can post it in the chat box, developed by the American Conference of Governmental Industrial Hygienists on aerosol transmission. And with that, I'm going to conclude, and I thank you. And if there's any questions, I'd be happy to take them at the appropriate time.
Thank you so much, Jonathan, for sharing this. It's a treasure trove of information. And, when I kind of sat through this presentation before, I just saw how much good stuff is there. So and I know you've got to pull away a little bit earlier, and I did say that we were going to reserve a little bit of time here for some questions for you. I thought what I'd do is maybe ask the first question. So if everybody looks down the bottom of their screen, there's a little face with a plus signal on it. So it's reactions, and then they can raise their hand there. And so what I thought I'd do is if somebody has a question, they could raise their hand. But I just want to kind of lead in this way. So my understanding is like $10 million were made available to develop this training material. And it's freely available. Anybody can access it online. If you think about the Occupational Hygiene Training Association, OH.learning, typically if you provide that kind of training, you need to be an authorized training provider. And I'm just thinking for people on this call looking at this training material, could anybody get in and use it or build on it, or just curious to know what your thoughts are on that.
Let me explain a little bit more. The National Institute of Environmental Health Sciences Worker Training Program is essentially a grant funding organization, and they have consortia, which are universities, labor unions, and other long-term providers of health and safety training. And it came about when the standard on hazardous waste operations was promulgated by OSHA. We call it HAZWOPER in the 1980s to deal with Superfund sites and hazardous waste sites. And so that's the core of that program. And that's about $30 million a year. And there's also been funding and training around disaster work and infectious diseases and small business and funding for environmental careers, which is directed towards low wage and minority workers. So there's a cadre of trainers, but here's the problem. OSHA just announced yesterday that they're going to be funding $24 million in training around COVID and infectious diseases. But the problem is if you don't have standards requiring worker training, it's going to be very difficult, even for these consortia of, that are made up of labor unions, organizations, committees for safety and health, clinics, and others. It's going to be very hard for them to get in the door and use that funding where it needs to be used, because there's no mandate. If there's no requirement, then you're basically going to these industries and saying to them, do it because it's the right thing to do. Well, we know that just doesn't always isn't enough.
Okay, great. So just building on that then, and one of the co-hosts has their hand up, so I'm not sure who that is, but I'm just thinking about what this training has, and I'm going to be kind of bold here. For quite some time, many of our colleagues have been told not to talk about airborne transmission or aerosol transmission. We've been muzzled, or people have been muzzled. And I guess from OCA, we've been fortunate because we've had the license to speak freely and look at the evidence and the science. So, on that kind of way of thinking, this training, does it talk about airborne precautions?
Yeah, the updated program definitely, talks about the fact that, we believe that inhalation, we use the word inhalation because one of the feuds between infectious disease experts and some epidemiologists and occupational hygienists is what's the meaning of the word aerosol versus airborne transmission. So to cut through all of that, we're just referring to it as inhalation. That makes it clearer. Basically, airborne is more like tuberculosis, which we know is a long distance, can be a long distance inhalation hazard, whereas with SARS, we think it's a closer range inhalation thing. But it's an inhalation hazard, and we've got that covered in the training, and we talk a lot about the importance of using ventilation. And again, we're not seeing the changes in the workplaces where people were infected and died to the ventilation that need to be put in place, again, because the requirements are not there. It's just guidelines.
Thanks, Jonathan. So I see that the person that had their hand up is Dorothy. Over to you, Dorothy.
Yeah. So thanks. And hi, Jonathan. Nice to see you. Long time no see. So one of the things that you basically said is that this ETS is not nearly good enough. I know a little bit, and we have heard almost a year ago about the California aerosol transmissible disease, aerosol, yes, ATD standard, transmissible disease standard. If people on this side of the border are looking for something that is a good regulation, is that one that you'd be recommending, and why?
Yeah, I mean, I think that one is much more comprehensive. It includes an appendix which lists, I think 30 or 40 different aerosol transmissible diseases. And it also identifies novel aerosol. So this was considered a novel aerosol transmissible disease. And, they have a much higher level of protection and requirements. And the problem again, though, was initially California OSHA was going to enforce this around SARS-CoV-2, and they were stopped from doing that, by the California Health Department. So, we need to have a seat at the table, both the occupational hygiene and safety and health professionals, as well as the labor unions and others that, care about the well-being of workers.
Mm-hmm. Yeah, thanks. And I've put links in the chat for the various materials that we've talked about.
And just on that too, Jonathan, we did have a presenter, actually Dorothy put her name forward, Deej Gold from California. And so we did actually have a webinar that included what's happening in California with their standards. So we could probably put a chat in that for people just to look back on that.
I can mention the first violation of that standard was first responders and it was Nosaria meningitis. So it was a medical call. The ambulance arrived, the police arrived, and they got infected. Some of the police got infected. The people riding the ambulance, for some reason, put on an N95 respirator. They did not get infected, but the cop was in the hospital for 2 weeks, and one of the hospital respiratory therapists did not wear respiratory protection and was hospitalized for 2 weeks. That was the first violation. So there's a lot of infectious agents, not just during a pandemic, that we need to protect people from aerosol transmissible diseases.
Right. Thanks, Jonathan. So we appreciate your time. And yeah, I think you could probably stay with us for a bit longer, but
Yeah.
if you need to pull away, we understand that. So thanks.